Right. So as I mentioned before we parted last week, we're going to only cover three traditional methods of treating cancer. So they are surgery, chemotherapy, and radiation. Let's begin with the oldest treatment, which was surgery. Okay, so in the olden times, when we first discovered tumors, cancer tumors, there was only one technology, which is to remove it. So surgical removal was the only way to remove it. Obviously, can we remove vital organs? Can you?
No.
All right, so we can only remove tumors that are on non-vital organs, the breast, the bone, the leg, okay, kidney, all right, on the abdomen, right, on the lung. Okay, so only um, non-vital organs. Okay, there are different types of surgery, so we differentiate them, or the surgical procedure is named after the purpose. Okay, what's the purpose of performing surgery? First type is diagnostic surgery. The most common example is a biopsy. So biopsy is a minor surgical procedure in order to obtain a tissue sample from the tumor. It can be accomplished with minimally invasive means by inserting a needle, for instance. The length of the needle will vary depending on where are you getting a tissue sample from. So if it's from a soft tissue, soft organ, or a solid organ, sorry, maybe the needle is anywhere from 6 to 8 inches. But if it's from the bone, for instance, let's say you need to get a biopsy of your bone marrow, then that would be a bigger and longer needle as well to burrow into the bone, the pelvic bone. All right, so that's the purpose of this surgery, purely diagnostic. Other surgical procedures that fall under diagnostic surgery is exploratory laparotomy. Okay, exploratory laparotomy, also known as XLAP. So, or people will just say, oh, patient had an XLAP. So that means they open the abdominal cavity, midline incision, pretty long incision from the epigastric area, and then they'll curve down, they'll curve around the umbilicus like a cul-de-sac. So the surgical incision will run down and then make a cul-de-sac curve down around the umbilical region and then straight down to the lower abdomen. So they'll open the patient up like a fish and then literally explore. Okay, so that's also a diagnostic procedure. They want to explore what's in there, right? Meaning they saw something on the X-ray, CAT scan, or MRI, and they're not sure what they're going to find. So that's why they do an exploratory laparotomy. I won't test you on the types of biopsies, but just in general. So what's the purpose of the surgery? If it's for diagnostic purposes, then we call it diagnostic surgery. Next is curative. Surgery can also be curative, meaning we are using surgery as the primary treatment. So we did that for Cushing's disease. We did that for pheochromocytoma. We can also do that for appendectomy or cholecystectomy, which is removal of the gallbladder, along with stones. All right. So many surgeries, but however, this is in cancer. So the purpose of this surgery is surgical removal of the tumor. Okay. Sometimes the surgery is the only treatment. However, most cases, the patient will receive two treatments, meaning surgery plus chemotherapy or surgery plus radiation therapy, or they may have all three, maybe surgery, or sometimes the order is reversed. They'll do radiation first and chemo, followed by surgery. Okay, so but that's not our decision. So if the purpose of the surgery is to treat it, then it's called curative surgery. It's also called debulking, meaning it may not involve one surgical procedure. It may be multiple. The first time may only be debulking, meaning we did not remove the entire tumor, only parts of it. But doesn't mean it's not curative, meaning just the surgery is just done in stages. Okay, so they'll remove part of the tumor today and then proceed or continue with chemo and radiation, and then after a while we go back in and finish the job. All right, so that's still curative surgery. So there's many ways to do that. Minimally invasive, using robots, for instance, or doing endoscopy, right? So we can do surgical removal of a tumor inside your esophagus or your stomach or any parts of your intestine endoscopically. Okay. So here are other techniques. I'm not really testing this, but these are advanced methods now of doing surgery. I'm sure you've heard of the CyberKnife, which is a form of radio surgery. So there's really no incision to speak of. So they use radiation technology in order to excise a tumor. Okay, so without cutting the patient. Okay, so they can do that now. Sometimes surgery will be called palliative, in which case, what's the meaning of palliative? What does that term mean? Palliation, palliative. That is to do what?
Isn't that end of life, like just comfort care?
It can, that's an example of palliative, but not necessarily. So you can do palliative care at any part of treatment. Okay, so yes, it's part of end of life care, but not
to reduce symptoms.
Correct. Okay, so when we say palliative surgery, that means it's only for symptom improvement. All right, but doesn't mean the patient is incurable or we're at the end of life. Okay, not necessarily. We can still do palliative surgery as part of curative, because as the example I gave earlier, maybe the tumor or the cancer is hard to get rid of. So we may need to do a series of surgeries. Let's say debulking first, cut the size down first, and then continue with chemo radiation, and then come later again, another surgery to finish it off. Palliative is part of that, okay? So don't think of palliative care as exclusively end of life. But yes, palliative care is always part of end of life, but doesn't mean that if someone receives palliative surgery that they are dying. That's not necessarily true. All right. So here are examples of palliative surgeries. Okay. Again, they're not really going to cure the cancer, but it will improve the symptoms, okay, until we can treat it either with another surgery or by other means. Okay. Prophylactic surgery, as the term means, what does prophylaxis mean?
Preventative, so before it happens.
Very good. So this is to prevent cancer. So here are some, either to prevent cancer or to prevent it from worsening, right? Or from developing. Let's example would be to, if let's say you have colon polyps. Colon polyps are known to become cancer. So at the polyp stage, we have the option to take them out. That's prophylaxis. Okay, and then the other examples here are colectomy, removal of the colon, mastectomy, breast removal, oophorectomy, ovary removal. Okay, so there's different ways to different types of surgeries depending on the surgical site or the organ involved. Again, what is likely removed here, a vital or a non-vital organ? Obviously non-vital, right?
Not vital.
So the organs I mentioned a while ago are obviously non-vital. We already talked about palliative surgery. So reconstructive surgery is, let's say, you lost your breast to cancer. So they'll do reconstructive surgery purely for cosmetic, but not 100% cosmetic. Sometimes it's also for body function restoration or improvement, right? So because sometimes they're beyond cosmetic repair. It's just the body part is so disfigured, so the whole purpose there will be just to restore function, or to we can also couple this with palliative surgery. Okay, but that's the purpose of reconstructive surgery. So, it's usually not the main surgery, meaning the patient had surgery or surgeries prior to the reconstructive surgery. As far as nursing management, our nursing care here, because the patient underwent surgery, so therefore, is it really different from pre and post-op care? General pre and post-op care, is it any different?
No, it's the same.
Okay, the same. So we already finished post-op care. So that's how it is. As far as your nursing care, it really depends. What was removed? Okay, so did the patient lose a leg, an eye, an arm, a lung, okay, a kidney, or part of the bowels, for instance, or all of the bowels? We don't know. Okay, so we just take care of the patient pre and post-op. Preventing post-op complications, nothing special. Any question on surgery? Very good. Let's go to radiation therapy now. There are two types of radiation. Radiation can be internal or external. When we say external radiation, we are referring to a radiation treatment center, or for instance, let's say you go to Memorial Sloan Kettering on the east side. So they have a radiation treatment room, or I should say rooms, and then you go in there, receive the radiation, and then come out and go home. So the radiation is in the facility. Okay, you did not bring the radiation home, the radiation source with you when you left the facility. So it stayed there in the room. You are exposed to it during your treatments, and that's it. The side effects mostly, I'd say maybe 90% of the side effects are local because the treatment is local when we say external radiation. The idea behind radiation is to expose cancer cells, but unfortunately also normal cells to radiation. So these gamma rays, and other radioactive material are of course very harmful to cells. Doesn't matter whether they're normal or cancer cells, benign, malignant cells. Radiation particles will harm cells and cause them to die. Some cells die today, right after the radiation treatment. Some die later when you go home, and some die a few days or a few months after the radiation treatment. So that's how it works. So it can be used for various types of cancer. We will talk about the oncologic emergencies later. There are 6 oncologic emergencies. We'll discuss them at the end of the chapter because they are emergencies. And we already showed you the NCLEX test plan. So every emergency must be discussed in school, in nursing schools, because they are on the NCLEX test plan. All right. So X-rays and gamma rays, electrons, beta particles, protons, neutrons, these are the different types of radiation we use to expose cancer. And don't forget, we're also exposing the normal cells together with it. So both normal and cancer cells will all die from radiation, all right? So they interrupt the strands of the DNA helix, and then that's how the cells die. All right. Dosage is determined by three things. It is the distance, okay? How far was the patient from the radiation source? Second is time. How long was the patient exposed to the radiation? And then third, was the patient wearing a shield during radiation? And if they were, what type of shield was used? Okay, so a few factors that will determine radiation dose. All of these, of course, are the responsibility of the oncologic radiation therapist. Okay, so your cancer doctor. That's again, the idea is to expose the cells, both again cancerous. Our target, of course, is a cancerous tumor. Unfortunately, can you reach, for instance, you have a tumor behind your nose, okay? So you have a nasopharyngeal tumor. How do we get there without exposing your skin, your muscles, your skull? Can we do that? Can we do radiation only to the tumor, or is it going to hit other structures in the process?
It'll hit other structures.
All right, so there will be collateral damage, okay, to the tissues, external tissues before we get to the tumor. So as I've mentioned, we have two types. We have external and internal radiation. Internal radiation, an example is brachytherapy. This is a type of sealed radiation. That's internal radiation. And then we also have unsealed radiation therapy in the form of radioisotopes. An example of the radioisotope was, remember RAI-131 we used to treat hyperthyroidism? Remember that? So that's an example of an unsealed radiation source. It's a form of internal radiation, but it is unsealed because the patient swallowed it, or it can also be injected, okay? So the patient either swallowed the radiation or they were injected with the radiation. Brachytherapy is usually using a sealed source, meaning the radiation, let's say this coffee bag here, no, this creamer bag, there's a radiation material in there. So I put it in this wrapper and then put it inside the patient. Does that make sense? Like a tea bag, okay? So let's say, imagine a tea bag, the tea is inside, the tea leaves are inside the bag, correct? So that's how sealed radiation sources are. So they have some form of applicator or a pouch, okay, that acts like a bag or a seal for the radiation.
What about capsules? Isn't
well,
also encapsulated?
No, if you swallow a capsule, I mean, the capsule disintegrates, so that's already an isotope, okay?
Gotcha, okay.
Unsealed radiation. Let's finish external radiation therapy first. So I described it earlier. So let's say you go again to Memorial Sloan Kettering. So you go for your radiation treatment there. You enter the room, you're exposed to radiation at a certain distance and a certain duration of, let's say, hours or minutes. And then you go home. So your body was exposed to radiation, your cells absorbed it. So you're not technically radioactive because you left the radiation source at the treatment center. You didn't bring it home. Okay, so you just expose your body to it. So that's all it is. No serious precautions necessary when you go home. Okay, you're safe to go home to your family. All right, let's go to internal now. So again, let me emphasize. So for external radiation, you are not radioactive, okay, because you never took the radioactive material with you. You just expose your body to it. Some cells absorbed it, and those cells, unfortunately, will die. We just don't know when they'll die. Again, some die today, some tomorrow, few days later, few weeks later, etc. And the frequency of your treatment, well, the doctor, the oncologist, radio-oncologist will decide how often you come for your treatments, okay? So they'll design your treatment plan with you. Let's go to internal radiation now. Now, this is way different because now the radioactive material is in your body. There are two forms. If it's brachytherapy, this is usually sealed. So the example I gave you was, let's say the radiation source is in a tea bag and the tea leaves are the radioactive seeds, okay, or isotopes. No, let's not use isotopes because isotopes are usually unsealed. So let's say you have seeds there or rods, for instance, okay, inside the tea bag, and we put that either inside your breast, inside your bladder, inside your uterus, into your cervix. Many ways we can insert a radioactive material. So the patient is
It's
carrying.
a surgery, right?
Sorry.
Would that be Would that be a surgery?
Not
And you
necessarily,
gotta
but
put
it is invasive. Depends. So let's say if it's from breast, if it's treated, used to treat breast cancer, that means it's usually applied after surgery. So let's say this is the patient's breast. So they made an incision, took out the tumor. So there's a space there, right? So right after
Yeah.
surgery, they'll put the implant into the void, where the tumor was. So they'll put it in there for a certain period and then take it out at a future time. So it's intended to finish off any cancer cells that they may have
Anything
dropped.
lingering, right?
Correct. So they can do that to finish off any tumor cells that they dropped during surgery. So to clean up their mess. Okay.
Yeah.
So if that's the case, the patient is radioactive because they have it in their body. Sometimes it's also, as I gave examples, so it's in your bladder. It can also be in your brain, okay? So they can also put it into the ventricles of the brain, inside the uterus, okay? So those are all examples of sealed radiation. So there's some container, okay, or an applicator holding the radioactive material, and then we will remove it, okay, at a future time. While the patient is carrying the radioactive source, now we have to observe radioactive precautions because it's harmful. We don't want to expose your family members, your kids, your spouse or your parents to you, right? Or visitors. So the general rule is, if it's a sealed radiation like this, doesn't matter what's in there, rods, seeds, beads, ribbons, or catheters. Okay, so these are radioactive materials. However, they have a seal around them, meaning they have some form of a container. We will approach three. We will observe three different things. So we will observe time. Okay, how long do we expose ourselves to the patient? Second is, besides distance, it's did I say time or distance first?
The time.
Okay, time. Okay, so there's a certain period of time that you spend with the patient. If it's a sealed one under brachytherapy, the rule is 1 hour. Okay, so you're allowed 1 hour per day. That's the total though. They don't recommend spending the whole hour continuously. So that's in short bursts. Okay, so short periods, let's say 3 minutes at a time, or do whatever is necessary. Okay. But if you're not doing anything, any direct care to the patient, try to stay far away. So the safe distance for sealed radiation is 3 feet. Okay, so time is 60 minutes, distance is 3 feet. But since we cannot insert a Foley, give an injection, or insert an IV catheter at 3 feet, can we? Can you do that? Are your arms that long that you can start an IV or insert a Foley from 3 feet away?
No.
No.
Only if you're Larry Bird.
Yeah, I don't think so either, because they may have long arms, but they can't see very well, right? From 3 feet away. So they may need to there are some things we have to do up close. So if that's the case, then we have to wear a lead apron from neck down. So you put that on, and then you perform whatever you need to do. But as soon as you finish, step back again 3 feet away. Okay, so to protect yourself. All right, so only a lead apron can protect you. That's the only approved barrier, okay, for radiation. Same thing, you've seen X-ray technicians, right? When you've gone for an X-ray of something, and you've seen them wear a heavy apron, correct? So that's the lead apron. So they put that on to protect themselves. Okay, so these people in the radiology department, they use those to protect themselves. Remember, radiation will cause another form of cancer, correct? So if we're using this to treat this particular cancer, it may predispose you to other types of cancer years down the road, okay? Because you were exposed to radiation, and radiation is a carcinogen. All right. So we said time, correct? So how long do we spend with a patient maximum?
1 hour.
How far?
Maximum.
How
3
far?
feet.
3 feet.
Okay. All right, that's good. Now let's go to internal radiation is not here yet, but let's just go down the page. So toxicity, remember, it exposes all cells, okay, not just the cancerous cells. It also affects the normal cells. So if that's the case, then you will have the following toxicities. The problems will be alopecia, okay, hair loss. There's also radiodermatitis, which is very painful. The skin will be so red, it can either be dry or moist, all right? So desquamation, meaning it will be flaking. The skin will be peeling off, kind of like after you've had bad sunburn, right? And then your skin starts peeling. Okay, so that's what it looks like. But it can either be dry or wet. But it looks painful. It's even more painful for the patient. Okay, so even looking at it, it's already makes you flinch, like that must be very, very painful. Okay. So because the epidermis is gone, then the dermis is exposed. That's really, really tender. It will be oozing fluid, okay, because now you have a broken skin. So the advice is not to, dress it lightly. Don't wear anything tight over it that will irritate the skin more. Don't put any powders or lotions there unless approved. There are As long as it's mild and your radio oncologist approves it, so that's part of the skincare we do for radiodermatitis. Okay. Do not expose it to sun. If you have to be outside with radiodermatitis, make sure you're wearing an umbrella or a large hat. Sunscreen is mandatory, but you shouldn't really be exposing that skin to direct sunlight anyway. Okay, I don't think a patient will anyway because it's really painful. The patient will also have, besides the skin, okay, because it was exposed to radiation, we also have the mucous membrane. So we will have mucositis, or also called stomatitis. When it says stomatitis, that means there are now large nickel, dime, quarter, or dollar coin size ulcers in the patient's mouth and tongue and gums. So that's all from radiation therapy. When we get to chemotherapy later, the same thing will happen. So besides the radiodermatitis, the hair loss, there's also the mucositis. Now, why is this important? Imagine you have these huge ulcers anywhere in your mouth and on your tongue as well. What will that prevent you from doing?
Eating and drinking.
Eating, okay? Eating, drinking, and swallowing. Sometimes the ulcers can go into your throat all the way to your rectum, all along your GI tract. You'll have mucositis everywhere. So that affects nutrition, correct? And once the patient stops eating, now what?
Lose weight.
They'll lose weight, they'll become malnourished. What happens to immunity?
Low.
That puts the patient at risk for infection. And once infection sets in, we already talked about and tested sepsis. Once the patient develops sepsis, then cancer treatment has to stop. We cannot continue unless we want the patient to die in the process. Okay, so the priority here is always to protect the patient, keep them from getting an infection. Sometimes it's not always avoidable. Okay, we can't absolutely protect the patient or wrap the patient in a bubble.
Can they give chlorhexidine, like mouth rinse and mouthwash to prevent?
Yes, that's part of the management. Well, the management is separate, so we'll get to the management of mucositis later. But yes, we will use they call it magic mouthwash, which is a combination of saline, benzocaine, which is a numbing agent, a topical anesthetic, and there's also an antifungal there because they assume the open source will develop fungal infections. Yeah, but nothing with alcohol though. So that's part of the management. Again, the patient will stop eating. Plus, we're not done here. We will look at other GI problems will continue. Is nausea, vomiting. So a patient will also have, on top of these large sores in the mouth, throat, and gums, the patient now has nausea, vomiting, and diarrhea. And that further impairs appetite, and the absorption of nutrients as well is affected. So now the patient is malnourished and they'll develop anemia. And then because this will also cause bone marrow suppression, so we'll continue here. Bone marrow cells proliferate rapidly, so therefore they're also affected by radiation. So the patient will have bone marrow depression or suppression. We also call that myelosuppression, so that the patient now has anemia, neutropenia, and thrombocytopenia. Okay, all three blood cells are low. We'll do management separately. So far we've done the acute effects of radiation. There are also long-term or late effects of radiation. Oh, I forgot a few things more with the ulcers. There's also xerostomia. This one. Xerostomia is dryness of the mouth. Now, if you've ever experienced dry mouth, you have no idea what dry mouth is because you still have your saliva. Okay, no matter how dry your mouth, I mean, relatively dry. Imagine if you have no saliva. Have you seen a patient with no saliva and what the mucous membrane and the tongue looks like in those individuals? It's dry, cracked, all right? And what happens if you eat with a dry mouth? Just imagine. Say
Painful.
you're eating toast, all right? Or mashed potatoes or whatever you're eating, chicken, whatever you're eating and swallowing. There's no saliva in your mouth. How will that feel? And what could happen to you?
You choke.
Can you aspirate?
Yes.
Yes.
I mentioned extremely difficult to swallow, correct? Plus, imagine your breath. What will your breath smell like when you have no saliva? I mean, it stinks enough in the morning, right? When your mouth is dry, how much more when you have no saliva, extremely dry. So that causes bad breath on top of all these problems, right? So we're not done yet. Fatigue also sets in. Now, unlike the manifestations we've talked about so far, which were mostly local, correct? This one is one of the systemic effects of radiation. So this could also be attributed to the anemia that the patient develops, but some patients have fatigue in the absence of anemia. I mean, some patients' blood counts are normal. Let's say hemoglobin is, let's say, 12 or 13. That's normal, right? However, the patient still reports fatigue. So there's a fatigue in cancer patients that are unexplainable. Okay, we cannot attribute it to anemia. Usually we blame anemia for the fatigue, but sometimes there's no justification why the patient experiences fatigue. Late effects are the following. So we have the acute effects so far up to here. Now we have late effects as well. So that this will occur 6 months to years after treatment. So we're not done yet. So this is now a consequence of radiation exposure. So remember the skin earlier where we had the radiodermatitis? Now the skin, especially if they receive long-term treatment for the cancer with radiation therapy, it will change color. It will not have the same texture as the rest of the skin in your body. The tissues will have these changes, loss of elasticity and vascularity as well. So they'll discolor. Some may develop fibrosis, atrophy, ulceration, and worse, necrosis. Okay, and some of these we cannot see externally because they're happening inside the body. Most of them are internal, let's say, for instance, on the lungs or in your brain, heart, and even your bladder. Okay. And lastly, we have sexual dysfunction. Okay, this is also contributed to by fatigue as well, and depends also on the site of treatment. So let's say the site of treatment involves the pelvis, then that will affect either male or female sexual organs, right? Or reproductive organs as well. So let's go to management now. So we did alopecia, mucositis, anorexia, nausea, vomiting, bone marrow suppression, fatigue, etc. All right, so here are your interventions now. Prevention of infection is our priority. but we cannot 100% prevent it. So the next step is early detection. So either prevention of infection or early detection of infection. Now, as far as early detection, keep in mind these patients are immunosuppressed. Remember, there's bone marrow suppression. So red blood cells, white blood cells, and platelets are low. So therefore, are they able to respond the same way as normal people? Meaning, will they show normal inflammatory responses to an infection? Like fever, malaise. Do they have normal inflammatory responses?
No.
No. So that means, can they develop a high-grade fever if inflammation is suppressed?
Yes.
They can mount a high temperature if their inflammatory responses are suppressed. Remember, the first part of immune response is inflammation first. So can they do that if they have bone marrow suppression?
No.
No. So that means do not expect a high fever in these patients, or do not wait for a high fever before you report to the physician. So any low-grade fever here is already an example of fever or a sign of fever in these patients. So no different from HIV/AIDS patients. So those patients also are immunocompromised, right? So those are in the same boat as cancer patients. So low-grade fevers in these patients are already a serious sign of an infection. So report it. Usually we report around 99. That's already considered fever in these patients. But normal people, 99 is normal, right? So fever technically starts over 100.4. So any 100 or 99 is already a sign of fever in these patients. So we're still in radiation. So radiation, we already talked about precautions. How far again for external radiation?
3 feet.
3 feet. How long?
Less than 1 hour, ideally.
Hour.
An hour maximum. Now, let's go. So that's right here. Now, if we have, that was for sealed, right? Okay, so let's do unsealed now. When we say unsealed, these are now the radioisotopes that the patient either swallowed or was injected into the patient. Injected either intravenously, intrathecally into the bone, or into the ventricle, or into any other body cavity. Okay, so the patient ingested the radioactive isotope. There's no covering on it, obviously, because they either swallowed it or it was injected inside their body. So therefore, does it enter body fluids now?
Yes.
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 So unlike in brachytherapy earlier, wherein it was sealed, they cannot enter body fluids. This time, since the patient's fluids are radioactive, so they involve saliva, feces, urine, reproductive fluids are all radioactive. Tears and sweat are okay, right? So any other wet stuff coming out of the patient except for tears and sweat are all radioactive. So because it is now unsealed, so how long of a time do we allow for visiting, including nurses? It is now only 30 minutes. And we must maintain what distance? 6 feet now, right? Again, for sealed radiation, how long?
Sealed is 1 hour and 3
1 hour.
feet. Unsealed is
30
me?
minutes.
And
And
now it's
6 feet.
6 feet.
All right. This dosimeter badge here is not the same as the lead apron. Okay, let me clarify that. This is not a lead apron. What is a dosimeter badge? This is only a sensor. They wear it on their pocket, okay, on their scrub. And this will determine, it will change color as the patients, I mean the person wearing it, it measures how much radiation they've already been exposed to. Let's put it that way. All right, so they must wear it, but it doesn't protect them. Okay, so what is the only protection from radiation?
What was the question? Sorry.
How do you protect yourself from radiation?
The lead vest.
Or the lead apron or vest. This one is not a lead apron. What does this do again?
Measures
It only measures radiation, amount of radiation exposure, provides no protection at all. So what we need it to make us aware of, let's say sometimes we have so much fun and we're in the room with the patient longer than necessary. And then so that will remind us, okay, you're already close to your time. You've been here way too long. Okay, so that's just a reminder, a warning. Okay, it measures radiation exposure. However, the protection, of course, is the apron. All right. Okay, that's for radiation. Skincare, again, even if the patient finished radiation, they are actually encouraged to observe the same skincare, the sunscreen, the when they apply cosmetics or any skincare products, they have to run it by their radiation oncologist first before using them. But generally speaking, the expensive ones, like Cetaphil, Eucerin, are approved. Okay, so they're really gentle, mild products. No Jergens, none of those perfume products you have. So only the non-allergenic or hypoallergenic, mild, preservative or fragrance-free products and skincare products and cosmetics are allowed. Okay. If you're not sure, run it by your radio oncologist. That's about it for radiation therapy. Let's take a short break before we go to chemo.